says let people know you are recording. All right, so today's respiratory emergencies, as we've done before, and as you've looked, respiratory airway is something very, very important for the body. It's the way that it gets what it needs. The oxygen gets rid of the carbon dioxide. It helps balance the pH level. So there's some very important roles with the respiratory system. Now, as we get started on this next section, part 9, is medical emergencies. And you notice that we've divided medical emergencies into 2 sections because there's a lot of information. So hopefully you guys have developed good habits to get you to a point where the quizzes and tests are easier. And for some of you, they are. And for others, you're still struggling with the exams. So we need to figure out a way to get you further up, because now it's putting a lot of stuff. We've already done the foundation. That's already done. Now, and we've already set the floor. So now it's a matter of putting up the walls and building the rest of the house. Okay. The thing about medical emergencies is that it's going to be a lot more difficult to determine what's wrong with the patient. Okay. With medical emergencies, you have to be a detective. You have to ask questions. You have to try to figure out what's going on with your patient. It's not as simple as it is with trauma. If they got a baseball bat to the abdomen, well, what do you think is going on? Possible internal injury, internal bleeding, right? Ruptured organs, depending on where it's at, we know the organs. So blunt trauma to the abdomen. Okay, that's pretty straightforward. But if somebody is, for example, in this right here, if they're having shortness of breath, well, what is that being caused by? We've already established, we've already learned how important the respiratory system is. We've already learned how to manage an airway. We've already learned about the pathophysiology of, bless you.
Thank you. I didn't want to see on camera.
That's okay. I think I have all 4 of you that are on camera right now anyway, so. For me, it makes it better for me to teach to actual faces as opposed to blank screens with letters on them. At least I could see the reactions. I think I'm going to get Luis a poster for his wall.
Decorations, at least.
Well, that's what I'm saying. Get him some decorations for his wall, a poster. I'll get him a copy of a EMS poster or something. I'll find something for him.
No, the human anatomy.
Oh, anatomy stuff, huh?
That works.
So with medical emergencies, again, respiratory, we've learned all that stuff. And so, number one, I'm not going to bore you to death again going over the respiratory system, the anatomy, because we've already learned it, right? We have the oronasopharynx, we got the larynx, we got the trachea, we got the carina, we got the bronchioles, or the mainstem bronchus, the right and left. We have the bronchioles, we have the alveoli, right? We know that the bronchioles are made up of smooth muscle, which constrict and relax. We know about albuterol that helps relax. It's a beta-2 agonist. In other words, it helps smooth muscle relax after it's been constricted. We know about giving oxygen. We know how to insert an NPA or OPA to ensure a patent airway. We know about giving a nasal cannula or non-rebreather when a person's having difficulty breathing. So we've learned all that stuff. So we're going to kind of put it together. I'm going to run a couple scenarios by you when the time comes, but let's start thinking. And I hope that you guys prepared for this chapter, because again, I'm going to ask you more questions. I'm not going to really review stuff, or I'm sorry, go over stuff that we've already learned. Even though it's a review, I think what I'm doing is going to be a better review. Okay. All right. So we got 2 EMTs. We got Luis and Valeria. They arrive at a residence to find a 62-year-old male I'm sorry, female, sitting in the kitchen or in the at the kitchen table, leaning forward on her hands to breathe. They immediately note that she is a thin woman with a barrel-shaped chest who's using accessory muscles to breathe. Okay. So as she's sitting at the kitchen table leaning forward, do we notice anything abnormal about that? What is it, Paul? So Paul, you're saying yes. What is it?
Oh, sorry. I'm on the phone with work.
Oh, okay. Sorry. I just asked the question. I saw you nodding your head.
Yeah.
All right, never mind. Go back to your phone call. All right, let's see. Mr. Joshua, what do you think?
When he first walked in, you said he was leaning forward, correct?
Yeah, she's sitting at the kitchen table leaning forward on her hands to breathe.
Yeah, the tripod position would be the first I would notice.
All right, good. She's tripoding. So right off the bat, we're right? And then she's thin with a barrel-shaped chest. So Miss Espy, what does that tell us? Miss Espy?
Is everybody on camera?
Nope. All right. So she's using accessory muscles. So Miss SB answered me. She is using accessory muscles, but the fact that she has a barrel-shaped chest, what does that tell us?
Is it chest pressure?
Okay, but what else does it tell us? Let's see. I'm not sure, to be honest. Okay, that's okay. So she's 62 years old. She's thin and she has a barrel chest. We talked about emphysema, didn't we? Which will cause her chest to be what? Anybody?
Is it inflated?
Yeah. How is it going to look?
It's gonna look inflated like a barrel-shaped chest.
Yeah. That barrel-shaped chest that this is talking about tells us she has emphysema.
Yeah.
And why is she using accessory muscles?
It's trying to like help like kind of like force oxygen into the lungs.
Okay. But in this case, is she using her hypoxic drive or carbonic drive?
Carbonic.
No.
Hypoxic.
Hypoxic. Remember, emphysema, she switched over. Because remember, air got trapped and damaged the alveoli.
Oh.
And so now she's using a hypoxic drive. It's the reverse. So in that hypoxic drive. But what is she retaining still?
Fluids?
No.
Carbon dioxide.
Carbon dioxide, right? So what is she trying to do that she's needing the accessory muscles?
She's trying to release it.
How?
Remove carbon dioxide.
She's trying to remove carbon dioxide. How?
But isn't it the vessels and the alveolus and they get bigger, right?
But why or how is she trying to get rid of the excess CO2?
By exhaling more.
Okay, give me a show or describe how.
Longer respirations.
More specific. You're right, but be more specific. What part of respirations? There's only two types of respiration, right? Or two
The
parts.
longer exhalations.
Exhalation, yeah.
She's trying to push out everything that's inside of her lungs.
Exactly. She's exhaling longer to try to expel the excess CO2. Okay. So now, despite an increased respiratory rate and increased work of breathing, her skin color is pink. So remember what I was talking about with Sequoia earlier about treating the patient and not the monitor. So her pink skin is telling us what?
That she is getting oxygen.
Yeah, she is meeting her needs right now. Now, who did I say? Oh, so Luis notices a portable oxygen concentrator as well as a nebulizer nearby. Is that to be expected for this patient?
Yes.
Yeah.
Yeah.
They have a type of COPD and they have emphysema, so they're going to be on an inhaler and a home O2. All right, so what is your general impression of this patient so far?
Respiratory distress.
Okay, but remember the general impression is there anything about the patient that's bugging you? Is there a no shit factor?
No, really.
No.
Her breathing.
Okay. Well, her breathing is fast, a little fast. She's tripoding. She's using accessory muscles, but her skin is pink.
Yeah.
So, is there really a lot that's bugging us about her?
No.
No.
No. Well, we need more information. What other information do we want to get a cleaner picture or clearer picture? Think about everything that you've learned: patient assessment, vital signs, monitoring devices.
Yeah. So. Patient
Pathophysiology. Okay, but what part of patient assessment?
Try to see if she could talk to you.
It's like saying,
Like
I want to get a car. What kind of car? A car.
Yeah.
Okay. Everybody wants a specific kind of car. It's like I want a pickup, but I got to wait a few years till I pay this one off, then I can get my pickup. So give me some specific stuff you guys want.
Her level of consciousness.
Level of consciousness. Well, we already got
She's
that. Didn't we?
conscious. Yeah, she's
Okay.
She's conscious. She's breathing. She's pink.
Her
Wouldn't
O2.
you ask like patient history?
Okay.
If they have like asthma, recent or like
COPD, emphysema.
Yeah.
But we have the pretty good clues that the patient does have emphysema, right?
Yeah. Ask the patient what is going on with them today, or
Well,
what's currently wrong with them, or what is the issue? What is
so
the
chief
problem?
complaint.
Chief
Okay.
complaint. Yes.
You're asking your sample?
Okay. Well, signs and symptoms, we see tripoding, we see accessory muscle use, we see increased respiratory rate, allergies, we don't know. Okay. So we can get some sample stuff. And in reality, it's ham, but okay, we'll get some sample stuff. What else?
Did you get an O2 reading?
A pulse ox, okay.
Oh, we should get her blood pressure and her heart rate.
Okay. So vital signs?
Vital signs. Yeah.
Okay. What immediate actions should you take while completing your primary assessment? Pulse ox, I'll give you that one. Pulse ox.
Lung sounds?
Lung sounds. Temperature, maybe now. So, do you guys enjoy breathing?
Yeah.
Yes. Mhm.
Yeah.
Is it a habit that you guys want to give up anytime soon?
No.
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 Okay. Have you ever found yourself in a position where something went down the wrong way and for maybe a split second or so, you couldn't breathe?
Yeah.
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 What did you do?
Gaps or try to, like, you panic.
Tripod position?
Well, maybe a tripod, but the biggest thing is once you panic, did your life maybe flash before your eyes? Were you like, who's going to take care of my kids now?
Oh, man.
That's driving every day on El Paso Highway right now.
Yeah, no kidding. I was supposed to be in the office. You notice my office today? It's not my office. I'm in my bedroom. I did shower and shave though, just for you guys. So I hope you guys feel special.
Oh,
It looks like Redoso.
It does.
Oh yeah, how about that?
road trip.
No, did you hear what happened? That they had a second person die from COVID, so they've shut down the res up there.
Wow.
Wow.
So much for going to into the Mountain Gods anytime soon.
They shut down what?
The reservation, the Mescalero reservation.
Oh yeah, they did that with the Navajo Nation right now. Like, there's National Guards there. That nobody. It's a 72-hour lockdown, and nobody can go anywhere.
That's how it was with the Tiwas. They put the cops at the entrances,
Yeah.
and they even put a curfew.
Yep. Ours too. Like, my mom has to go onto the reservation to feed the horses, but she has to have a special permit to get on.
It's getting more and more crazy. But breathing is something that we enjoy and we don't give it up. And so think about how you've gotten when you couldn't breathe. So imagine how your patients are going to be.
Yeah. Distress.
So we've talked about the signs and symptoms before, about how it's quiet. What are other characteristics of normal breathing?
Skin color, temperature. The well, like temperature is warm. Skin color is pink. The skin is I think is moist, right?
In normal respirations?
Well, norm. Well,
You'll be dry.
Dry? Yeah. No.
Yeah. What else? What other characteristics?
Proper rise and fall of the chest.
Okay, equal rise and fall of the chest. What else?
Normal amount of breaths per minute.
Normal
Okay,
mental
normal
status.
respiratory rate. Uh-huh.
Normal mental status.
Okay. What else? I mean, you guys aren't telling me the stuff that I told you, but I mean, that's all good stuff to have also to assess.
Are you
Huh?
to see if it? Well, I was gonna say primary or secondary if you need to redo it or.
No, what I'm saying is, remember we talked about normal breathing and abnormal breathing.
Oh.
And I said, so we've said equal rise and fall of the chest, normal respiratory rate. What's the effort like?
Relaxed.
Effortless.
Yeah, there's no effort whatsoever, right? That breathing is quiet.
You also have good communication. They're not having trouble with speech.
Okay, normal speech, normal number of breaths or words per breath. Okay. And then the abnormal is the opposite. It's noisy. There's work. You might see accessory muscle use. You might see abdominal breathing, seesaw respirations. So it's more of what you're seeing with the breathing. Yeah, the skin signs can be pelvic and diaphoretic, but we already know why because of the pathophys part that we learned, right? That the body needs that oxygen in order for it to function. Peixes bem, peixes, Mina, come. 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 Okay, she's eating again. Good. All right. So we went over breath sounds. I'm trying to remember if you guys had Myra. No, you guys didn't. I'm hoping you got shown where we check. So I only have 5 of you on camera.
My camera's not working.
No. I know what it is. Oh well. So George, show me where you look for or where you auscultate lung sounds.
It's second mid clavicular right here,
Okay.
and then mid axillary fourth or fifth intercostal,
Okay.
and then in the back, it's right by the scapula. I guess circling it.
Okay.
1, 2, and 3, like going down.
Okay. And what sounds are you looking for?
Clear sounds.
Okay. What are the abnormal sounds you might hear?
Wheezing for lower, stridor upper, crackles, that would be lower. Rhonchi as well.
Okay.
Oh, and bilateral breath sounds.
Okay. All right. So based on what we have learned, like I said, that was a quick review. And we talked about asthma before, right? What is asthma? Or am I assuming?
The constriction of the bronchioles.
Okay.
It's a respiratory spasm, like within the lungs, causing like difficult or like an allergic reaction.
Okay. It's narrowing of the bronchioles caused by mucus buildup. That's constricting the bronchioles, the passageway through. All right. So here's your call. So you respond out to 456 Amy Street for a report of a person with difficulty breathing. Timeout 0400. Oh, I just love those calls. Okay. So since we've learned patient assessment, go through. What are you going to do? And I want to hear from others that I'm not hearing from. Like Kevin and Amber and Gerardo and Kurt and Elena, and I usually hear from Demia, but I haven't heard from her today. Caesar, Jennifer. So walk us through. Somebody, anybody.
Scene size up.
All right. The first thing is the scene size up.
So,
Although I've already heard from you today, Aaron. That's why I didn't call your name, but keep it
yeah.
up.
Pretty much head to toe. You start off asking the patient what is wrong today, and you start assessing them from the head down to the toes, like how we did, I guess.
Okay, but before we get there,
Yeah.
so first off, scene size up. What are we looking for in the scene size up?
Seeing what exactly like happened, looking around the area for, I guess,
For safety, like hazardous, wasty.
Yeah, remember the definition I gave you for the scene size up, or the purpose of doing the scene size up.
Yeah, I think so.
So what is it?
Penman.
Panman. But that's what you're going to use. But remember, the purpose of the scene size up, the purpose of the scene size up is to make sure it's safe for you to get out of your vehicle, and then is it safe for you to approach your patient?
Yes.
Hay personcita me está haciendo la vida difícil. So that's the purpose of the scene size up. Okay. And what do you use? You use Penman in order to do that. All right. So what does Penman stand for?
PPE, picking the environment.
Okay. So PPE and environment. So there's nothing outside of your ambulance that will hurt you. So we'll clear that. So now you're walking to the door, you're let in, and the only thing you notice when you walk in is that the TV is on, but the volume is very loud. Okay. So what's the next part you're going to do?
How many patients?
All right. Number of patients. You only have the one. We'll call him Caesar. We'll call him Caesar. So what's next?
Mechanism of injury.
All right, mechanism of injury or
Nature of illness.
nature of illness. So let me see. What you see is a adult patient with shortness of breath. Okay, what's next?
As you approach him, you can determine the level of consciousness.
We're not there yet.
Oh.
We're not done with scene size up.
Okay. Oh, additional resources.
Okay. Would you call any additional resources?
ALS if you need to.
Okay, possibly ALS. All right. And then what else?
That's it for scene size up.
Nope.
The need for
The need for extrication and free spine.
Okay. And he's sitting on his in the living room. So is there a need for extrication or C-spine?
No.
No. Okay. So now what's the next part you're going to do?
Your primary assessment.
Okay, which is
Your sample.
no.
Your general impression as you
Okay.
approach him.
It's poor. You hear audible wheezes
Yeah.
as you're approaching him, and he's tripoding. Okay, what's next? So somebody's that level of consciousness. He's alert. He's tracking you. He let you in.
if he needs it.
What was that?
Assisting the airway.
How?
Right. If he can't breathe, if his tongue is in the way.
Okay. What I meant was, how are you going to take care of the airway?
Oh.
Because you said that's what you're going to do. Now tell me how you're going to do it.
Oxygen.
How much?
15.
2 liters.
12 to 15 liters.
I want you guys to be decisive. And remember, whenever you're giving drugs, remember the drug, the dose, and the route. So you're telling me O2. I heard 2. I heard 10 to 12 or 12 to 15. I heard 15. So somebody make a decision. The drug, the dose, and the route. Huh?
What was the saturation?
You guys haven't asked for it yet.
Oh, yeah.
You need to determine how much oxygen his pulse ox is.
So what is it?
Yeah.
Are you going to do it before or after you give him oxygen?
Before.
Okay. Is before SpO2 is 91%.
How's his pulse?
Just say you want vitals.
Vitals, yeah.
All right. Vitals.
What vitals do you want?
You already established his skin temperature, color, and
No, that's all part of vitals.
His O2 reading.
So
All right.
what vitals do you want? You want skins? Talked about pulse ox. What? Somebody said pulse. What else?
Blood
pressure.
Blood pressure,
Okay.
temperature.
Get the respiration rate.
Okay.
Do that as you get the pulse.
Okay. Okay, for the third time.
Pupils.
What is his overall vital signs for everything?
Well, before I give you vital signs, I want to know what vital signs you're looking for. And I gave you guys that acronym.
Well, we're looking, since he's having trouble breathing, we will look at their O2 along with their breathing.
Pulse, respirations, blood
Pulse.
pressure, eyes, lung sounds, level of consciousness, skin signs. And then
Yeah.
throw pulse ox in there as well. And there was an S. I forget right now. So remember those vital signs, PR bells. Remember that?
Yeah.
Okay. PR bells. Pulse, respirations, blood pressure, eyes, lung sounds, level of consciousness, skin signs. All right. Pulse rate of 118, blood pressure of 140 over 100. Respirations are 26 and labored. Temperature is 98.9. Like I said, pulse ox is 91%. His GCS is 15. Skin signs are normal. I don't believe it. What else do you want to know? Oh, S, sugar. Skin signs and sugar.
Yeah. So that's like glucose levels?
Yep. And his glucose is 88.
Okay, that's good.
That's not good.
Well,
It's low, but it's not too low. I like to think about a range of 80 to 120.
yeah, 81.20, that's what I'm saying.
All right, what else do you want to know? So we did general impression, we did chief complaint, which is our level of consciousness. We said he's alert, and then the chief complaint or apparent life threats. What's his chief complaint?
Difficulty breathing.
Yeah, shortness of breath.
Yeah.
Okay, and then what do we check?
The constriction of their eyes dilate or if they constrict.
We're not there yet.
No.
We're not in the secondary yet. We're still in the primary.
All right.
So you see how I told you guys we already built the foundation. We went through patient assessment.
Yes.
I taught you patient assessment. I taught you the way to do it. Okay.
Yes.
So I'm just trying to show you how we put that together when we show up at scene.
Okay.
Okay. So I don't want you jumping around too much. I want you to start developing, kind of thinking mentally as you go along. And then remember, I taught you Penman 331. So we did the first three. What's the next three?
Well, isn't what cheaper complaint is one, right?
Chief complaint.
That's one.
Well, we already established chief complaint.
Yeah, I already did. Yes.
Okay. Now we're in the second three. What's the first part of the first or of the second three?
Assess airway and breathing.
There you
Airway.
go. Remember, airway, breathing, circulation. So assess the airway. Like I said, his airway, you hear audible wheezes, but there's no stridor. What's next?
Breathing.
Breathing. He is having difficulty breathing. He has sternal retractions.
Yes.
What's next?
Circulation.
Circulation, although this is why I didn't agree. It said skin was normal, but actually his skin is pale, slightly pale.
Yeah.
So what is that telling us right now? With what we have so far, what is that telling us?
He's low on oxygen.
Hypoxic.
Okay, he might be, yeah, he is hypoxic. What else?
Wait, you say the skin is what?
Pale, slightly pale.
Slightly pale. Let me see.
So
Telling
it's
us he needs oxygen.
huh?
It's telling us he needs oxygen.
Yeah.
Okay, he's hypoxic. He needs some oxygen. He's not perfusing very well, probably, right? Although his blood pressure is high, but is that to be expected in this patient?
Yeah.
Yes.
Okay. So with the rest of circulation, like I said, his pulse was 118. What are the things that we're checking for in circulation?
Capillary refill.
Nope. So
That's
make
10.
sure you go back over your notes on patient assessment, because
Skin
I'm going to be doing some scenarios with other medical emergencies. Remember, with pulse or circulation, we're checking the rate, rhythm, and quality of the pulse, which
Okay.
is 118, strong and regular. We're checking for looking for and controlling any major bleeding, and there doesn't appear any bleeding. This is a medical call, not a trauma. And the last part is the skin signs, which we said he's slightly pale. So with the information we have right now we move to the one. Is this a load and go or stay in place situation?
Stay.
Same place.
Stay in play.
Oh,
Oh no.
Gotta go.
Oh, because of the circulation.
yeah, he's in severe respiratory distress. You guys told me he was hypoxic,
Remember, he's pale,
Yes.
bro. Pale, so like.
and he's pale.
Yeah, that's bad.
Okay. And now you guys never did finalize how much oxygen you're going to put him on.
The 12 to 15.
Yeah, 12 to 15.
Make a decision.
12
Non-breathing.
to 15 liters.
Huh?
No. 12 to 15 liters non-rebreathing.
Make a decision. I don't want to hear ranges. I want to hear exact. I want you to make a decision.
15.
15 how?
Non-rebreathing.
Non-rebreather.
So oxygen 15 liters via non-rebreather mask.
Yes.
Okay, perfect. All right, so moving on. Now we move into our secondary. So
Okay.
in the secondary on medical assessment, what we're doing first off is the sample, right? So we already got vitals. Now we're going to do sample, signs and symptoms. Do you have, I think you have enough signs and symptoms already, right?
Yeah.
Yes.
Now what's a sign versus
Yeah.
what's a symptom?
The symptom is what you cannot see, and a sign is what you can.
Okay. The other thing I throw in there is something that you can't see or prove, like
Okay.
pain. You might be able to see pain, but how can you prove it?
You can't.
Yeah.
Unless
Can't
what
even, huh?
what about with the patient? Like he can tell you where the pain's coming from, no? So wouldn't that
Correct, but again, can you prove it?
No, you can't
Right
prove
now, Sequoia has a headache. Can
Yeah.
we prove that she has a headache?
it. If she's grabbing her head.
No.
She's hungover.
No, I'm not. I really do.
So when your girl tells you, "Not tonight, dear, I have a headache," can you prove that she doesn't have a headache?
Not really, no.
Are you
Until I
ballsy
found
enough to
out.
say, "No, you don't. You're just lying to me. You just don't want to have some happy adult time"?
Yeah.
I guess I took the girl, the victim here.
Until you kiss the happy place. Yeah.
But remember that with happy adult time, it releases endorphins, which opens up blood vessels, which in reality helps improve headaches. But see, you guys didn't know that before. Now you do, and now you be like, "Hey, honey, it's proven.
Yeah.
I'm gonna help your headache go away."
That's why I said once you start kissing the happy place, then everything changes.
Yeah, but women are different.
Hey.
Some are. Some are. Dude. Some are pretty.
See, for guys, it's easy. There's really only one happy place. For women, you gotta actually work at finding it.
I could
Shoot, I forgot this is being recorded.
Yeah, we could get pretty.
I gotta delete that part. But anyway, no, but like I was saying, with symptoms, you can't prove it or you can't see it. Remember that pain is subjective. So even though you could put a number to it, that number is different for everybody. So like if I were to ask Rosie on a scale of 1 to 10, 10 being the worst pain you've ever felt, what number would you put it at? And she tells me, oh, it's a 9 or a 10. Well, I know she has kids, so I'll ask her, compared to childbirth, how does this compare? And if they tell you it's as bad as childbirth, that's a woman's 10. But you ask a guy for a 10, and it'll tell you when they stub their toe at night with their bed as you're walking to the bathroom, right? That's a pretty bad feeling. So everybody's pain scale is different. So yeah, you can measure it, but you really can't because it's so subjective. Everybody's pain scale is different. All right. So as far as signs, what are signs? Things
Signs of
you
pain.
can see or prove. So if I say the patient's been vomiting, can I see it or can I prove it?
Well, they could prove it too, you know.
Well, yeah, it can be seen or proven.
Yeah.
Hey, here you go. Here's my vomit from this morning. See? Or better yet, when they vomit on your hand when you're not wearing a glove.
Yeah.
That happened to me at a show we were working at. Had a girl that was drunk. I think she was underage too, but she was drunk. She could barely walk, and she'd been puking. So we get her in the tent. She's been puking into this plastic bag, and then I sit next to her to reassess her. All of a sudden, she wants to puke again, and getting ready to go, I didn't have time to grab a glove. I grabbed the plastic bag and I put it up to her. Just as I was bringing it up, she vomits, and she vomits on my hand without gloves on.
Did you throw it back?
What was that?
Did you throw it back?
No. I put it in there, cleaned it off, washed my hands and stuff. Luckily, because I can't do body smells. I can stand blood, guts, and gore all day long, but when it comes to number one, number two, or vomit, forget it. I'm or toe jam, forget it. I just thinking about it. Gosh, ugh. See, I get grossed out, but I can see gore. I can see missing limbs. I could see gnarly lacerations. I got pictures when we do soft tissue injuries and trauma. I got pictures of a shark bite, shark attack. Oh, I can't wait for Saturday where I can do another, where I can make myself another ribeye. I made myself a ribeye on Sunday. It came out delicious. Let me tell you, I was in heaven. It was better than sex, or so they tell me.
Yeah.
Whoa.
That steak was delicious.
You
I'm a
sure?
guy. I'm a carnivore. Okay. It was Memorial Day weekend. I cooked up a ribeye.
Are you sure it's not the cake, the one that's called better than sex cake?
Yeah. Are you sure about that?
No. Stop it, guys.
I don't know. I don't think I've had cake that's better than sex.
I know
No,
there's
that's
a
called.
mascara, but not a cake.
What?
I
The
know
cake
there's
is
a
called.
mascara like that.
I can't hear. Everybody's breaking up.
Go for it, Rosie.
Go for it.
I was saying that they have a cake that's named that. That's what I was saying. Like, are you sure it's not that?
Well, I'm sure. It was a ribeye steak. It was a ribeye steak.
I'm hungry now.
Mhm.
Well, good. All right. So symptoms, and then what's after that?
Allergies.
Allergies. All right.
Isn't that like
Allergic
considered like
to
medical
medication.
history?
What?
Isn't that considered just medical history?
What, allergies?
Well,
It's
allergies
separate.
and all stuff. Oh yeah.
Well, remember, we're doing samples, signs, symptoms, allergies, and he's not
Yeah.
allergic to anything. So
Yeah.
what's the next things? What's the M?
Medication.
Medications. So he takes an albuterol inhaler. What's next?
Past medical history.
Past medical history, and he has asthma.
So his last oral intake. So his next, the last or the next thing.
Nothing.
Wouldn't it be the event prior to the event, or what has led to it?
Nothing. It just started about 30 minutes ago.
You said he has a inhaler, correct?
Yes.
Would we be able to put that with the last oral intake? Just see what his last or what the events prior? When was the last
Sure.
time you took it?
Sure.
So either or. Last
Well,
oral intake
as far as last oral intake, yeah, he took his albuterol a little bit ago. There was no improvement with it. And then the events leading up, it's more of what provoked it. Okay, so we did the sample, and now what are we gonna do?
The GSC,
The what?
the GSC, the score on the
Yes,
oh yeah.
she says she's at 15. Now with signs and symptoms, what are we looking for? What questions are we gonna ask? I can't breathe. Please help me. It's getting really tight.
Would you ask when did it start at that time? So you kind of know.
30 minutes ago.
Has it gotten worse?
What makes it better?
You ask him if he took the albuterol.
All right, one at a time. Let me answer one at a time. So
Not everyone's
Just-
answer.
yeah. So first off, all I was doing was I was outside having a cigarette when this started. And then what was the other question?
I guess you would ask if he took the albuterol.
Which she did. Remember,
Which
we
she did?
established that with the last oral intake.
Oh, okay, 30 minutes ago.
So what you guys got to do is you got to write down the answers so you're not asking the patient the same question over and over. Because what's
Okay.
going to happen is it's going to piss them off. They'll be like, "You're not a patient paying attention to me." Trust me, it's happened to me before. So make sure you guys are writing down these answers so you are not asking the same questions.
So then, would you go from did it get it any worse after the intake?
All right,
After
let me organize it for you. OPQRST. You see how it's all coming together, coming into play together? I told you we built that foundation. So everything we're doing now, it's based off of what we've already developed with you guys. That's what I was saying. Now it's starting to put up the walls and start making the rooms. We've already got the foundation. We've already put down the floor. Now it's time to start building the rest of the house. So OPQRST, you asked me onset, said about 30 minutes ago. Provocation, non-provoked. Q quality, and somebody asked, is it easier to breathe in or out? And it's easier to breathe in. Radiation, non-region, chest. Relief, I didn't get any relief with my albuterol. Reoccurrence, I have a history of asthma, and I've been intubated 3 times before. Since you guys read the chapter, what is that telling us?
COPD.
Nope. He does not have a history. He's 24 years old. Granted, he smokes 2 packs a day.
That the
If a patient has ever been intubated as a result of asthma, that's going to tell us that they get bad to the point that they need to be intubated in order to help them breathe. So are we sweating ourselves and saying, oh shit, I better get this guy better soon?
Yes.
Yes.
Yes. That's why we went with load and go. Okay. The other thing is you guys need to talk to the patient a little bit more. Hi, sir. My name is Paul. I'm an EMT. What's going on? And you see the tripod. I can't breathe. Now that's going to tell you, do you really want him to tell you a dissertation when he's out of breath?
Yeah.
So maybe now we need to do closed-ended questions. What's the difference between an open-ended question and a closed-ended question?
Open-ended question.
It's more of an explanation.
Yeah, where they can go on. And what's a closed-ended question?
It's one word answer. Yes.
Yes or no.
It's a simple answer such as yes or no. So you hear I'm saying I can't breathe. So that tells us we're going to use closed-ended questions. So asking them, do you have a history of asthma? Do you have a history of COPD? Do you have a history of this? Do you have a history of that? Do you take albuterol? Do you take any inhaler? Instead of saying albuterol, which would probably be the easiest thing, ask them, do you take an inhaler? Yeah. Where is it? Do you have it with you? It's right here. All right. Have you taken it already? Yes. Did it help at all? No. Okay. So what can we do based on what we learned in pharmacology?
Tell him to take the albuterol again.
We're going to help him take his albuterol again. Because wasn't there a question maybe where the guy, you asked to see how he did it and he just sprays it in front of his nose? Does that sound familiar?
Yeah.
Yeah.
See, there's a method to my madness. But this guy, that's exactly what he did. Even though he has a history of asthma, he usually has to call 911 to help him out because he still hasn't learned. He's stubborn. He's a Mexican male that's very stubborn. That's not true. I just made that up. Right, guys? And it's awfully quiet all of a sudden. But anyway, so the inhaler, that's what he does. He sprays it in front of his nose and he's trying to suck it all up as it's sprayed in front of his nose.
It's like one of those the people at the mall with the perfume. Smell this, smell this.
You walk right through the mist.
Yeah.
Yep. Okay, so what are you going to do? So we're going to assist him with it. What other, or we did lung sounds, right? Because that was part of PR bells. Lung sounds were, you have bilateral wheezes in all fields.
We can probably, if the albuterol still doesn't work, we can probably put him on O2.
Well, you've already have him on O2. Remember, it was 15 liters via non-rebreather. So we're going to assist him with his albuterol all the way it should be. Sound good?
Yeah.
Yeah.
Okay. So how often are you going to reassess him?
5 minutes.
5 minutes.
Every 5 minutes. Okay, we do the rest of our secondary, the kind of a focus history and physical. The only other thing you know is that he's upset because he can't breathe. So you reassess his lung sounds at 5 minutes, and then he has diminished wheezes now. His respiratory rate is now 22. His blood pressure is 118/70. His SAT is 95%. Pulse rate is 96. So what happened?
He's improving.
He's
He's
improving.
getting better.
Okay. Now, if you're in a system where you can administer albuterol, not a system with his own inhaler, but you could actually set up the albuterol inhaler or nebulizer.
Yeah.
You would do that. What's the dose?
1 bullet.
1 bullet. Did you put anything else in that with that inhaler?
Nope.
No.
No.
Doses.
Okay. So I think with my evening class, they were told to dilute it,
No, I think that was
or was
us.
it you guys?
It was
Okay.
us talking about diluting it with water. That's what it said.
Yeah.
Yeah.
Yeah, you don't need to dilute it. It's already in diluted form. So just put in that one bullet of albuterol. That's it.
Yeah.
Okay. All right. So you're transporting him, and you get to the local hospital where he gets better. Okay. Questions?
No.
Nothing.
Does that make you guys think?
Yeah.
You guys hate me?
No.
Nope.
No.
You guys seeing why it's important to review the previous stuff and why I've put the videos up?
Yeah.
Yeah.
Are you guys gonna be ready for me tomorrow with cardiac emergencies?
All day, sir. Yeah.
We try.
Yeah.
That's all I ask for, is that you try.
That's funny.
Yeah.
And I want to hear from people that are quiet. Again, Caesar, Elena, SB,
Do they have
Frankie,
camera?
Kevin. No.
You know what you should call him, sir? You should call him
I
the no
have been
screeners.
talking.
I'd be calling people.
Call them what?
No screeners? You have no
Oh.
screen?
Oh, I've called them. Hey. Push one. Push one. Push. My doggy's getting mad at me. She's getting jealous.
Mine's just being stubborn. I'm not wanting to come in the house.
Now this one didn't want to go outside the house to go to the bathroom. And she wakes me up at like 1:15 this morning because her water bowl was empty. So she wanted me to open the door, and she ran to the kitchen to drink out of her water bowl out there. And it's like, oh, okay, I get the idea. So I got some water and I brought it in here for her. And now she's happy.
Dogs are sometimes picky.
Yeah, they are. Especially the female dogs. Oh, precious. She loves it when I'm here and she hates it when I'm not here. And last night she was outside my door for, I don't know, over half an hour. She was scratching it and crying because she wanted me to let her in. But I locked her out because she, in the middle of class, she just got up and she wanted to go outside, I thought, to the bathroom. And no, she just wanted to leave the room. And so I'm like, okay, I'm busy here. And then I said, go with your mom, with my mom. And my mom came out. She heard that, and she was going to take her, and she ran right inside my room and hid. It's like, for all intents and purposes, she's my dog. Even though it was my dad's dog, but since she knew my dad passed, because she stopped doing what she did for him. But now she does it to me. She'll wait for me. When I get home, she runs at me and she jumps up on my leg and starts turning and getting on her stomach, and I scratch her and everything. So she gets happy. So anyway, something else that we can do for respiratory distress patients. We talked about did we talk about CPAP?
Yeah.
Yeah, I thought we did. Remember, continuous positive airway pressure. So what are the indications for us to utilize CPAP?
What medication?
What was that?
What was your question?
What is the indication? Why would we put someone on CPAP?
Because it pushes air pressure down.
Okay, that's the action. It keeps the airways open by using continuous positive airway pressure. Okay, so that's the action. But the indication, somebody with COPD, somebody with emphysema, somebody with CHF or asthma, right? Contraindications are what?
Smoking.
What? That the patient is unresponsive or sleeping.
So, hey, Luke, I was gonna ask you, whenever it comes up to that CPAP, I was reading that you can give um, too much air.
Mm-hmm.
How would you know, like, if it's too much air? Would they start with do you see expand? Would you see like the chest or stomach? Would you see
No, because
Because-
they're breathing it in. It's going to the lungs, but you're altering the blood chemistry.
Oh,
But the sign is like they start getting sleepy, don't they?
Yep.
that they what?
They start getting sleepy, like they start losing consciousness.
Um,
Trying to find something else to do. So we were talking about this guy, this asthmatic patient. So what do you think his status was?
Of the patient that we just assessed, or
Yeah. Yeah.
no, give me two. See, there's a big word in there. I think I put it in there. Did I? No. Oh, you know what's in the garage on the kennel? On the what? On the kennel. Can you bring it in?
In other words, so the guy was bad. He was in respiratory distress, right?
yes.
Yeah. Now, what we're trying to do is prevent him from going into respiratory failure. In other words, his body is no longer able to compensate. Okay, pulse ox is not too bad. I mean, it's low, but it's not too bad. We could do CPAP. They're in respiratory distress. Now, with respiratory failure, that's what we're trying to prevent him from going into, because he does have a history of asthma. Basically, now the rate or the tidal volume are inadequate, where you do have to assist him with ventilations by a BVM, because he's unable to maintain that respiratory rate. You'll see the respiratory rate maybe start to go up as he's having a harder time breathing, but then it's going to start decreasing, and not in a good way. Remember I said about treating the patient, not the monitor, and it could be a pulse ox or something else. But if his respiratory rate is going down, but his skins are still crap, in other words, they're still pale, cool, diaphoretic, what else are you going to see with somebody that's having that's hypoxic? Besides the respiratory rate, what else should you see?
cold and clammy, like their skin signs.
Okay, the skins. Okay, the skins are abnormal. What else? What do you think, Valeria?
What was your question?
What else are you going to see in the patient that is deteriorating? Because he's hypoxic. What else can you see?
He's gonna have a rapid breathing and a fast heart rate.
Okay. So we're still seeing a high respiratory rate, high pulse rate. But remember, as he's starting to go into failure, that respiratory rate's going to start going down.
Confusion, maybe.
Why?
Because there's not enough oxygen going around through the body.
There you go. He's not perfusing very well at the brain. And the brain is very susceptible to changes in oxygenation. So is he having a hard time getting oxygen into his body? Yeah. So is he having a hard time circulating enough oxygen to maintain perfusion of the vital organs? Yes.
Yes.
Okay. So respiratory failure. If it continues, what stage are we going to go into? And it doesn't have to be Valeria. I want to pick on Kevin since Kevin's been quiet. Oh, Kevin.
I'm here, sir.
So what stage are we going to go to if it continues to deteriorate?
Would it be shock?
No, we're past that. So we have respiratory distress, respiratory failure, and then what's the last one? What do you think, Frankie?
Cardiac arrest.
Not yet.
Well, if he's respiratory arrest.
There you go. He's going to go into respiratory arrest. The body couldn't maintain it, so it goes into respiratory arrest, which means
He's no longer breathing. His lungs are no longer functioning.
there you go. He's no longer breathing. So, Miss Jennifer, what are we going to do then?
Apply oxygen.
How? It's one of the skills you guys learned last week. It's what?
Would it be the BVM?
There you go. But I wanted Jennifer to answer it. So, Jennifer, what are we going to use?
BVM.
BVM. How much oxygen in that BVM?
I'm not sure, sir. I didn't want to.
Yeah. Take a
Okay.
guess. We've been mentioning, and we talked about it in airway management when we did that chapter. How much oxygen do you think we're going to be giving this patient? A liter flow. Miss Elena, what do you think? Miss Elena, can you hear me? Send me a message. Let me know you can hear me.
I can hear you.
Okay. So what liter flow would you put this patient at? Give me a number.
I want to say I'm not sure on that one.
Just give me a number. Give me a number between, I'll make it easy for you. Give me a number between 1 and 15.
What was it?
What was that?
15?
15?
Yes.
All right. Good job. All right. Abe, is there anything else you would do or use for this patient that's in respiratory arrest? Mr. Abraham. Mr. Abraham.
Yes.
What else would you use on this patient in respiratory arrest?
They're already on oxygen.
Mhm.
And wouldn't I reassess them afterwards?
Eventually you would, but before you do that, I want to know what else you use on this respiratory arrest patient.
I'm not entirely sure.
Again, this is something you guys learned last week.
Is we CPR?
No. We don't know if we need CPR yet, but we're trying to prevent that.
Follow your ABCs, your airway.
Well, okay, airway is open, but
Yeah.
I'll give you a hint, Abraham. How do you make sure you maintain an open airway?
With the head chin tilt maneuver
Head
or
tilt,
the
chin lift,
thrust.
okay, but that's not that's opening up the airway, but that's not ensuring an open airway.
Okay.
So I want Abraham to tell me.
Sure.
Yeah, the OPA, the
Okay,
device.
what's OPA stand for?
It would be inaural pharyngeal airway.
Okay. And what if he has a gag reflex? Then what?
Pull it out a little further.
Just a little further?
Well, all together and then re-measure it.
Well, no, he has a gag reflex, so is he going to keep it?
So,
No.
No, because what does the gag reflex do?
Prevents anything from really
It doesn't
inhabiting that
prevent.
space.
No. Well, the gag reflex is a reflex that makes you want to do what?
Vomit.
Vomit. So if you keep putting that in there and he has a gag reflex, eventually what are you going to make him do?
They would vomit. So then we would stick the one, use the NPA,
Okay, which stands for?
nasopharyngeal airway.
There you go. We're going to use an NPA. All right. So we're ensuring an open airway. We're breathing for the patient. We're checking a pulse. They have a pulse. So we're going to deliver one breath every how often?
5 to 6 seconds.
Every 5 to 6 seconds. Good. Okay. All right. We have to make sure we keep oxygen going because the heart's going to need it. The brain itself is going to go about 4 to 6 minutes without oxygen before there's irreversible brain damage. The heart can go how long without oxygen?
No more than 10 minutes.
Yeah, it can go up to 10 minutes. After that, the heart's dead and it won't come back. So that's why we need to get the oxygen in there. That's why we need it. The heart's still working as long as it gets what it needs. Okay. Just like, guys, if you take your girl out every so often, spend a little bit of money besides the dollar menu, she'll stick around. If not, she'll find somebody that will take her out. Okay. Tell me I'm lying. Tell me I'm lying.
Well, tell that to Rosie. She'd like to take her dates on a dollar menu.
I mean, can you get more food with off the dollar menu? Yes.
Rosie?
She can, but then she'll be like, "You're just trying to get me fat, so I don't go out with anybody else. I look unattractive to other guys." Of course, we're not going to tell them the truth, but you just don't want to go through that argument.
Well, then just limit it to like 3 little burgers. That's it.
Or just offer her a salad.
Oh, that's even worse.
Just give him a glass of water.
Diet water.
On the rock.
Diet water on the rocks. Okay. Can you believe this, Precious? The heart needs to be taken care of. We need to give the oxygen because without the heart, everything else is going to die. The body can live without the brain. It's not going to be a very fulfilling life because they're dead for all intents and purposes, but they can keep the body going as long as they have them on a ventilator, which is providing constant oxygen. So the heart's not going to do it any different. It's not going to get any sympathetic or parasympathetic stimulation, but it's still going to keep on going as long as we keep providing it oxygen. Okay. All right. Damn. So as far as the other conditions, we've talked about the COPD, we've talked about emphysema, right? We talked about chronic bronchitis.
Very briefly, you didn't really go over it.
Okay. So what's happening with chronic bronchitis really is it's bronchitis. It's just with COPD patients, it's chronic because there's a lot of mucus buildup there. So the bronchioles are swollen, they're thickened, they're reducing the flow of air through that particular area. The alveoli aren't really being affected. It's the bronchioles that are being affected. So what happens is, again, the reduced airflow through those bronchioles. So one of the things that causes, or one of the primary causes of chronic bronchitis is smoking. It's just irritated all the time, and eventually that mucus builds up and it doesn't go away. So the person's going to have what we call a productive cough because of all that junk in their bronchioles. When they cough up, some of that mucus might come up. So a productive cough is where they're actually producing something with that cough. Whereas a non-productive cough, that's a medical term for it. A non-productive cough is a cough that nothing comes up. So nothing came up. That was an unproductive cough. But if I start coughing and I start kicking up phlegm, then that's called a productive cough. Now, albuterol will cause, remember, it's a bronchodilator. It's a beta-2 agonist. In other words, it helps stimulate beta-2 receptors. And so it relaxes smooth muscle. It causes it to dilate, bronchodilation. So with that, if there's any junk in the lungs, they're going to start loosening up that junk. And so when they cough, they're going to have a productive cough. And it's okay. It means they're trying to clear up their airway. So that's a good thing. Okay, so that's a normal side effect of albuterol use or administration is a productive cough because it's helping get rid of that stuff. The other thing that's also going to do,
It can always lead to ammonia, right?
It can lead to what?
Ammonia.
High ammonia levels?
Yeah.
It can, but there has to be a lot of use of it. So, how do you think we're going to treat a chronic bronchitis patient? O2, huh?
You can probably give them a treatment.
Yeah, O2, albuterol, maybe CPAP.
CPAP.
Do what?
No, I said CPAP.
Okay. Now, the other thing about these patients is number one, they need oxygen. A normal COPD patient, which chronic bronchitis is a type of COPD, remember, they're now in the hypoxic drive. So we don't want to give them too much oxygen. When they're in a hypoxic level, would normally be hypoxic for others, for them it's actually normal. So we don't want to give them too much oxygen because that could knock out their respiratory drive. Now, if they're having severe respiratory distress, pale, cold, clammy, tripoding, the whole 9 yards.
Yeah.
Do we give them high flow O2?
Yes.
Yes, we do, because they're still needing oxygen. And the amount of time that we have in the pre-hospital setting is not enough to really knock out the respiratory drive. We're improving them. So with that, the doctors will adjust their oxygen levels to get them back down to normal. So yes, we can give them. Some people might tell you, no, you don't give them oxygen, you're going to knock out the respiratory drive. Yes, that's true. But you could tell them the amount of time that we have them under our care is not sufficient to knock out the respiratory drive.
Yeah.
Okay. All right. So going back here. So Luis quickly notes that as Valeria applies oxygen by nasal cannula and begins asking Mrs. Brown's friend some questions. Mrs. Brown is in tripod position using pursed lip breathing. Is that a bad sign?
Yes.
Yes. She is anxious and is able to speak 3 to 4 words at a time. Is that bad?
Yes.
Yes. Her respiratory rate is 28 with adequate tidal volume. So what are you thinking?
Oh, shit.
And?
So you need to hurry up and transfer them to the hospital?
Would you do anything else?
Yeah.
What? And don't say pray.
For a miracle?
You are the miracle.
Yeah.
So what do we do? Caesar, what do you think?
Yeah. Right.
I can hear Aaron.
Yeah. Sorry.
It's all right. I'm waiting on Caesar.
Could you repeat the question?
My question is, what else would you do for this patient that's breathing 20 times a minute and is in tripod using pursed-lip breathing and speaking 3 to 4 word sentences?
I mean, you'd probably want to go through your primary assessment.
Okay,
Check
we've already done that. We're doing our secondary.
secondary.
So I'm talking about treatment. What else could we do for treatment for this patient?
Administer oxygen.
Okay. How?
It'd be through, since they have patent airway, just go ahead and do it. What's it called? Nasal cannula.
Okay. What's her respiratory rate?
Okay, so it's gonna be probably like non-rebreather mask then, up to like 15. Yeah.
What's her respiratory rate?
For average would be 12, 20.
No, for this one.
You said it was 22?
Nope, 28.
28.
So would you keep her on the mask?
No, probably move her to CPAP, possibly.
Okay. What else can you use? At a rate of 28.
I'm
What
not
do you
really
think,
sure.
Marcus? Huh?
Yeah, we're gonna use a bag valve mask
Why?
because it's greater than 24, which is the threshold.
There you go. Remember what I told you guys. Less than or equal to 8 or greater than 24, you utilize positive pressure ventilation, which is a BVM. Now, CPAP is also good. Somebody's squeaky toy. All right, so moving on. Auscultation reveals scattered wheezing and rhonchi throughout both lungs. So this is almost like the last call, the 24-year-old. Her pulse ox is 94%. The friend states that she has emphysema and has been more short of breath than usual since early this morning. Okay, so she's not doing so hot, right?
No.
Nope. So would you characterize her condition as respiratory distress, respiratory failure, or respiratory arrest?
Failure.
Distress.
I would say respiratory failure.
Her pulse ox is still pretty good. Yeah, she has pursed lip breathing. She has wheezing. She's tripoding, pursed lip. I think she's still in distress.
All right.
She's close to failure, though. I'll give you that.
Cool.
All right. What treatments may be appropriate for her? We talked about BVM. We talked about CPAP. Anything else? Again, think about the scenario we ran with that 24-year-old guy with asthma.
If he has albuterol.
Okay. And she does take an inhaler, right?
Yes.
Yes.
But if not, can we give her some? Maybe.
Yeah.
Yeah. So how should treatments be integrated with plans for transport?
You put her on the oxygen, then you prepare for transport.
Okay. While bagging her, maybe you could set up the albuterol on the BBM.
Yeah.
Okay, questions?
Nope.
No. All right. So we talked about asthma. We know it's a constriction of the bronchioles, plus there's mucus buildup, mucus plugs. We talked about albuterol being able to take care of that. Asthma is more prevalent in females than it is with males, although males also get it. However, severe enough asthma attacks, basically an asthma attack without any type of relief with albuterol is considered to be status asthmaticus. So that is a life-threatening asthma attack where people can die from it, and people have died from status asthmaticus. So need to get a little bit more aggressive. As EMTs, there's not a lot of stuff that we can do. We can give albuterol, we can bag the patient, give them high flow too. But other than that, there's not a lot of stuff. Maybe we could use CPAP if it's available to us to kind of keep the airway open. But like I said, one of the big points in the medical history taking is asking if they've ever been intubated before. If they tell you yes, then that should let you know that this patient gets bad. So you need to be aggressive. I'd like to find it, and I know somebody was telling me about watching episodes of Night Watch, and so there is an episode of Night Watch where they come across this asthmatic guy, and this guy had been intubated 18 times. So so they threw him on CPAP, and Dan is saying, we don't want him to get intubated the 19th time. We're really working. You could see the guy. Remember, he's having a hard time getting oxygen in, right? And as we established earlier, if he's not getting that oxygen, he's going to become drowsy. So that's how we know, kind of also with respiratory failure, he's not getting enough of what he needs. So that patient ended up getting intubated a 19th time.
Yeah.
So that tells you that if they get intubated, they get bad, and we need to get them to the hospital. Now, with an asthma patient, if you can, try to get an intercept, because not only as a paramedic, not only can I give them albuterol, but I could also give them maybe what we call a dual neb, which is albuterol and also Atrovent, also known as apatropium bromide. That's another beta-1 agonist. It lasts longer than albuterol. I could also, at least in my system, I could also give them solumedrol, which is a steroid, which helps reduce inflammation. So whenever possible, try to get ALS there to take over the patient for you, because we don't want that patient to get bad. Okay.
Would you be doing the same thing for like asthma attacks that are triggered by different things and not necessarily like someone who gets an asthma attack not doing really much, like
What, like anxiety?
like
Oh,
someone
that's
that
not an
has
asthma attack. That's a panic attack.
Well,
no, like from allergies or something, or like
Yeah, asthma can also be triggered by like seasonal allergies, or when they're allergic to different things like animals, pet dander, grasses, pollen, that kind of stuff. Yeah, that's the same thing. It's triggering an asthma attack, which is causing a constriction of the bronchioles, causing a buildup of mucus. So yeah, you would treat it the same way. Some get exertional asthma. In other words, they play sports and they have asthma as a result. And so I've known people that can't participate in PE because of their exertional asthma. Exertional basically means that they're exerting themselves, they're working out, breathing a lot, that causes an asthma attack. And there are some, as you were saying, that just sitting there, they develop an asthma attack. Now, with that scenario that we did, that 24-year-old guy, I talked about how he just went outside to have a cigarette and started developing shortness of breath. Now, I kind of laughed at it. And yesterday I was doing this with my advanced class, and I didn't give him the time. But with you guys, I did. And as soon as I saw it, I don't know if you guys noticed, I chuckled because it was at 4 a.m. Now, I'm a smoker. But I don't get up in the middle of the night just to have a cigarette because I'm craving a cigarette.
Yeah.
But
Yeah.
I've been on that call where it was about 4 o'clock in the morning. We get that respiratory distress. We show up, and what do I find outside? A cigarette that's still smoking. And they live alone. It's like, really? You're calling us for this at 4 o'clock in the morning? 3 o'clock in the morning? You can't breathe before you just finished a cigarette. Yeah. So, I mean, it can get bad. Now, there's rapid onset and slow onset asthma attacks. The slow onsets, like I said, primarily affect women, whereas the rapid onset primarily deals with males, or more prevalent in males. And that's usually more of the allergic reactions, the allergens, the pollens, the cat, the grasses, that kind of stuff. I talked about exercise and also stress. It's that rapid onset asthma that's more likely to lead to death than the slow onset, because rapid, it came on suddenly and it deteriorates very, very quickly. So, wrong button. So, from what we have learned, can you think of anything else different for treatment for an asthma patient?
Sit them upright, like an upright position.
Yeah, and they're going to want to be sitting upright because they can't catch their breath otherwise. What else? Really nothing different. Okay. So, George, he's 75. And he has trouble breathing. And so Andrew is the EMT that goes on George. So George, sorry, not George. Andrew, wake up.
Yes, sir.
All right, just making sure Kevin's not playing with you or anything. Trying to keep you safe here. So go ahead and assess George.
What's the like?
That's for you to determine.
Okay.
You respond to a 75-year-old male who's not feeling well.
Okay. I walk in the door, right? Good afternoon, sir. What's the problem today?
I can't breathe. I feel like crap.
Has it been going on for a long time, or was this just recent?
It started last night.
Okay. Are you having any pain? If so, is it sharp or not?
Yeah, my chest hurts.
How would you describe it from a 1 to 10?
It's about a 3 or 4.
3 or 4. Okay. Any medical conditions?
I'm 75 years old. What do you think?
Most likely, but I mean, I don't know.
I'm grumpy.
Okay. What are the vital signs?
What vital signs do you want?
Blood pressure, pulse, and SOP. SPO.
What?
Bad.
Oh, pulse ox?
Yes.
What else?
Lung sounds. Because he's having chest pain. No.
Okay.
Yeah, kind of.
Now here's an important thing, and since we're doing cardiac emergencies tomorrow, whenever you have a patient complaining of either chest pain or shortness of breath, Ask them if they're having the other.
Excuse me?
Rule out the other. In other words, if they have shortness of breath, do you have any chest pain with that? Yes. What came first, the chest pain or the shortness of breath? Or if they have chest pain, do you have any shortness of breath with that? Yeah. What came first, the chest pain or the shortness of breath? So when you asked George that, he says, do you have shortness of breath? Yes. What came first, chest pain or shortness of breath? Well, the shortness of breath. Okay. So maybe you still want to rule it out, but it's a good indication this is not a cardiac related. This is respiratory related. That's George, by the way.
Damn. He sounds old.
He's 75, and it's not old.
Sounds like he's a smoker.
Probably vapes a lot.
Maybe not.
Yeah, he probably does vape a lot.
Probably.
You know what happened to my evening class that gave me shit about my monsters?
We're talking about George.
Yeah, I'm just talking about vaping a lot, though. Oh, I ripped into my night class. They were shaking. Ask Ricardo over at Clint what happened.
Oh, I'll ask him.
Because he's the one that got smacked upside the head by me. Not really, but not literally, figuratively. Or ask Claudia, either one of them. All right, so so you saw what George was doing. So now what do you got to think?
You're asking me still, sir?
Yep.
Oh, okay.
Unless you want to have Kevin answer it.
He's lost. Probably put him on an armored breather.
Okay.
Because I mean he's still breathing on his own. Probably help him out.
Okay.
And then you want to see if he gets better or if he worsens.
Okay. What else? It's a respiratory patient, so what do we want to do?
If he's been intubated before?
Well, does he have a history of asthma?
We don't know. I asked him if he had a history of any medical history.
And what did he say?
That he was old.
Uh-huh.
So I need to know if he really has any other medical history or not.
Okay. And he says he has high cholesterol and he has ED.
ED?
Yeah.
That stands for edema, right?
Nope.
Erectile dysfunction.
There you go.
Oh, true. So he drinks erectile dysfunction pills.
Well, no, he doesn't drink. He takes.
He takes.
But does that have anything to do with what's going on?
Not really, because he's
having trouble breathing.
Yeah, because
it has something to do with
So what do you think we want to do? Don't forget your patient assessment. So you're getting history. What else do we need to do? How about your physical exam? What part of the physical exam you want to do?
Head, toe.
How about lung sounds? It's
Yes.
a respiratory patient. How about lung sounds?
Yes.
I had
Okay.
said that.
Your lung sounds reveal bronchi. What else you want to do? How about skin signs?
Yes. Skin signs.
Remember your ABCs?
Yes.
So your
blood
skin
pressure.
sounds are flushed, hot, and dry.
Mm.
So you got bronchi and hot, flushed, dry skin. So what are you thinking about? Ow. Ow. Ow, that hurts. In other words, can patient have chest pain from a lot of coughing?
Yes.
Yes. So Andrew dropped George's trousers to take a rectal temperature.
What?
And the temperature is 101.2.
Is a fever.
So he has a fever also. So what are you thinking about now?
Infection.
What kind?
Respiratory infection.
What kind?
Bronchitis. Or
Is his lungs crackly or?
No, they were bronchi.
the bronchi.
That's it.
Pneumonia.
Pneumonia. Well, why pneumonia?
Because of the bronchi.
Okay. And so what's
And the
happening?
fever.
Okay, and the fever. All right. So what's happening in pneumonia?
There's an infection in your lungs.
Specifically the alveoli, isn't it?
Okay. There's an infection in lungs in the alveoli. And so what else is going on?
So it causes like inflammation in the
lungs.
pus starts filling in the sacs.
In the
Okay.
lungs. Yeah. Doesn't it cause fluid buildup?
Okay. Where?
In the lungs.
Okay. So fluid in the lungs.
Yes.
And why is that a problem?
No to exchange.
Why? That sounds
Because of
like
the-
Kevin. Oh no, it's George. Okay. Keep going. My bad.
Because of the fluid in the alveoli, it's preventing from the oxygen to cross over.
Okay.
Yeah.
Which means
Low perfusion.
Hypoxia.
why?
Yeah.
Why what?
Why is the patient hypoxic?
Because of the low gas exchange that are poorly exchanged to.
Oxygen's not being sent into the capillaries by the alveoli because they're infected.
Okay. So I was trying to see if you guys remembered exactly what I told you, and that was oxygen does not diffuse through fluid.
Oh yes, that's true.
Okay. There's a blockage of fluid blocking the oxygen.
Exactly. And it's an infection, so the patient is not able to get enough oxygen. Oh, I'm sorry, because it's an infection, they're going to show signs of infection, the fever, the dry flushed skin, dry flushed hot skin. So that's what pneumonia is. It's an infection. Now, what you have to understand about pneumonia is it's a very opportunistic bacteria. In other words, it waits for your immune system to be down. So if you've had the flu or a cold, is your immune system going to be down?
Yes.
Yeah. So that's when pneumonia comes in. And it can be worse for elderly patients. That's why they have actually a pneumonia vaccine to help prevent pneumonia. Back in the early 1900s and even into the 1800s and before, if someone acquired pneumonia, they could die from it. It was pretty bad. But we've got to the point where it's not so bad. You know, that's where we'll hope COVID-19 is going to be soon, is where it can still kill people just like the flu does, just like the cold does, or pneumonia, but it's not going to be an election year and it's not going to be that big of a deal. So, okay.
With pneumonia, can it be dry or wet cough?
Well, it could be, yeah, it could be a little bit of a wet cough or productive cough.
It depends on the severity, doesn't it?
Yeah. So, all right, let's take a break. I have 10:09, be back at 10:20. I'm sorry, 10:25.
All right.
Ready?
Cool.
All right. It was fun.